Hello everyone, welcome. Let's learn anesthesia from basics. Today we will be discussing about emesis and antiemetics. First, before we go into the topic, let's discuss what is meant by nausea. Nausea is a subjective feeling of the need to vomit, and vomiting is a complex process which begins with contractions in ileum and jejunum. This contractions moves the contents back into the stomach. So the contractions will make all the contents will move all the contents back into the stomach. After this, the glottic opening is closed to prevent regurgitation and to protect the airway. And there will be contraction of diaphragm. This contraction of diaphragm creates a negative intrathoracic pressure, which causes the pharyngeal sphincters to relax. And at the same time, there will be contraction of the abdominal muscles. This causes a rise in intra-abdominal pressure. This raised intra-abdominal pressure compresses the stomach, which causes emesis. This is the highly orchestrated mechanism of emesis. This emesis is centrally controlled by a vomiting center, which consists of nucleus tractus solitarius and parts of reticular formation in medulla. When it comes to vomiting center is regulated by various neurotransmitters. The different types of neurotransmitters are acetylcholine, GABA, cannabinoids, then dopamine, substance P, and serotonin. So these are the various neurotransmitters which act upon the vomiting center and triggers the vomiting center. So after this, there will be activation of histamine, muscarinic, opioid, dopamine, and dihydroxytryptamine, which causes nausea and vomiting. To remember this neurotransmitters acting on vomiting center, go with A, B, C, D, dopamine, P, substance P, serotonin. Yes, for us. Go like this. And nausea and vomiting. As everyone know, there is another zone called chemoreceptor trigger zone. This chemoreceptor trigger zone is located in area postrema on the floor of fourth ventricle. This is located outside the blood-brain barrier, and this is the chemoreceptor trigger zone, which is easily triggered by various stimulus like sight, smell, taste, pain, hypotension, hypoxia, hypotension, hypoxia, and raised ICP. All these stimulus will trigger the chemoreceptor trigger zone, which in turn triggers the vomiting center. Not only the chemoreceptor trigger zone, but vomiting center is individually triggered by various other factors like drugs, which we use, opioids, all the anesthesia medication which we use, chemotherapeutic agents, surgery, toxins, gastroparesis, motion sickness, and middle ear surgeries. This chemoreceptor trigger zone via the cranial nerves 5, 7, 9, 10, and 12 through vagal parasympathetic and sympathetic fibers, and also through alpha motor neurons to skeletal muscles. The efferent signals will go through these pathways. So now we saw what emesis and how the emesis occurs, the mechanism and the central mechanisms happening in the emesis. we'll see what are the risk factors for development of postoperative nausea vomiting or perioperative nausea vomiting in patients. First, women, non-smokers, any history of motion sickness, previous history of postoperative nausea vomiting, long prolonged surgeries, use of volatile anesthetics. These are the various children more than 3 years of age, ear surgeries. These are the most common risk factors for the development of postoperative nausea and vomiting. Now we saw what are the risk factors. Let's see what are the strategies to reduce this risk. First, avoid GA, avoid general anesthesia. Use regional anesthesia whenever possible. If general anesthesia is needed, go with propofol for induction and maintenance of anesthesia. Avoid nitrous oxide for long surgeries lasting more than 1 hour. Avoid volatile anesthetics. Minimize the use of intraoperative and postoperative opioids. Adequate hydration to the patient. And use sugammadex instead of neostigmine for reversal of neuromuscular blocks. Now we have seen all the process. Let's discuss the drugs. For the drugs, let's go back to the neurotransmitters which we have seen acting on the vomiting center. As we have discussed, acetylcholine, GABA, everything. So the pharmacological therapies for the treatment of postoperative nausea and vomiting are serotonin receptor antagonists, anticholinergics, cannabinoids, dopamine receptor antagonists, neurokinin receptor antagonists, and H1 receptor blockers. These are the various drugs which block the different neurotransmitters at the central level and at the peripheral level for the treatment of nausea and for the prevention and treatment of nausea and vomiting. Let's go with individual drugs. Some examples for serotonin antagonists, we have ondansetron, tropisetron, granisetron, dolasetron, and palonosetron. Most commonly used is ondansetron, 0.15 mg per kg oral or 0.05 mg to 0.15 mg per kg intravenously. Ondansetron most common side effect is it causes QT prolongation. The other group of drugs, anticholinergics. In this most commonly we use scopolamine for motion sickness. We find this as a transdermal patch which is most commonly placed post-auricularly, and which the patch should be applied 4 hours before the noxious stimulus, and it releases at a rate of 5 micrograms per hour, and for 72 hours the absorbed dose will be less than 0.5 mg, and after the removal of the patch the half-life will be 9 hours. The other group of drugs, H1 receptor antagonists like cyclazine, promethazine, diphenhydramine, and dimenhydrinate. Dimenhydrinate is used. Dimenhydrinate. Dimenhydrinate is used for postoperative nausea, vomiting, and also motion sickness. Diphenhydramine doses 25 to 50 mg per dose of diphenhydramine. The other group of drugs, dopamine receptor antagonists. Dopamine receptor antagonists, they have a central side effect. Look, extrapyramidal side effects also are there. In this group of drugs, we have benzamides, butyrophenons, phenothiazines, and amisulpride. In benzamides, we know the most common drugs which we use, domperidone and metoclopramide. The difference between these two are domperidone do not cross blood-brain barrier and metoclopramide crosses the blood-brain barrier. So metoclopramide has higher chances of extrapyramidal side effects compared to domperidone. In butyrophenons, we have haloperidol and droperidol. Haloperidol in the dose of 0.5 to 2 mg IV and droperidol 0.65 to 1.2 mg IV. Phenothiazines, chlorpromazine is given. Chlorpromazine doses 10 to 25 mg per oral or 25 to 50 mg IV or IM. Amisulpride is given at the dose of 5 mg IV over 1 to 2 minutes prophylactically. Amisulpride 5 mg IV over 1 to 2 minutes for the prophylactic treatment of nausea and vomiting, and for the treatment part it is 10 mg IV over 1 to 2 minutes. The other group of drugs are neurokinin receptor and neurokinin 1 antagonists. These are aprepitant, fosaprepitant, casopitant, rolapitant, vestipitant. This aprepitant is available as 40 mg oral capsule. This neurokinin 1 antagonists are most commonly used for chemotherapy-induced nausea vomiting and radiotherapy-induced nausea vomiting. The other group of drugs are cannabinoids. The available cannabinoids for us are nabilone and dronabinol. Other group of drugs which most commonly we see in our OTs are benzodiazepines and corticosteroids. Benzodiazepines, midazolam 2 mg IV 30 minutes prior to the finish of surgery, prior to the end of surgery, if we give, there is 80% decrease in the incidence of nausea and vomiting in the patients. And corticosteroids, dexamethasone is used. Ondansetron 4 mg, dexamethasone 4 mg or droperidol 1.25 mg administered IV as prophylactic therapy is equally effective in reducing postoperative nausea and vomiting. So, ondansetron 4 mg, dexamethasone 4 mg or droperidol 1.25 mg are equally effective. That's it for today. Thank you for watching. Please like, share and subscribe.